How does one start a lecture video? Anyways, we're back with another one. This one is on Parkinson's disease. So basically, Parkinson's, we kind of all really know Parkinson's. It's like the shakiness type of stuff. Um, but this is kind of, I just want to get a good review in for myself. So the patho is something that I struggle with the most, but I pulled out my big ass book, um, and it said that basically you have dopamine and acetylcholine. They're like inverse relations of each other, and acetylcholine is like the when it stimulates the substantia niagara right here. It's like excitatory, like um, what is it called? Um, they're inhibitory and excitatory effects on the muscles. So acetylcholine would be like the excited part, and the dopamine is what like inhibits it. So essentially, Parkinson's is the degeneration of this substantia niagara, and this is where the dopamine is coming from, which means now there's way more acetylcholine and not enough dopamine. So essentially, acetylcholine is like triggering the excitatory muscles of your body, but there's nothing to match it, you know? So it's making smooth, controlled movements difficult, essentially. So there are main four symptoms of Parkinson's: trap, tremor, rigidity, akinesia, and postural instability. Akinesia, I think, is like the shakiness, has to do with the shakiness. Postural instability, it's like, well, it's mobility issues. This Parkinson's is all under the concept of immobility, which I did yesterday. Um, basically, they Parkinson's is like hard to diagnose because I can't remember. It's just it kind of matches mimics aging. It's maybe it's like asymptomatic, but essentially, but it's not like lethal. So it's just you're more. It's like a spectrum. I think they have it down here. You don't really know you have Parkinson's until it's too advanced, and this can be over like 15 years. So the example they gave us was if a 50-year-old is showing early signs of Parkinson's, you're probably not going to know until like 65. And one of the things the professor really stressed to us is Parkinson's itself doesn't kill, it's the complications that sometimes make it fatal, you know? So your early signs are subtle. They could be, I have written down asymmetrical, so maybe like one side of your body you have symptoms and not the other. But as you slowly go along, then you have tremors starting up. You have difficulties in your activities of daily living. Once you get halfway through, you're starting to have like mental impairments. So your movement is slowing. You have a loss of balance. And then up here is more like you just can't live alone. You need assistive devices to move around, like a cane or walker. Advanced is like bedridden. You can have hallucinations, like stuff like that. So complications, um, falls and injury. That's all about the immobility because you have one of the signs and symptoms of Parkinson's is that tremor, that rigidity, and you're unstable and you're shuffling, so it makes you more prone to falls. The aspiration, hmm, I'm not too sure. I'm over here filming this and I have absolutely no idea what I'm talking about. Um, I think aspiration mostly because it can get harder to chew, it can get harder to swallow, so it makes you at like a bigger aspiration risk. Malnutrition, this one's a big one because again, you can only eat certain things because you're having trouble swallowing and chewing. Um, but also because for certain medications, I don't think you're supposed to eat a diet high in protein because that can what's it called? What's it called? Impair absorption of the medications. Um, UTIs, tissue breakdown, constipation, loss of independence. That one's easy. Caregiver strain, financial strain. That's one easy because they need a lot more help, like a lot more help. But oh, but going back to the little spectrum, one of the things that the professor had said is the younger you are, the more likely those early symptoms are not going to be masked due to age. So the people who are like, I don't know, in their 30s or 40s, I think if you that'll be easier to catch and you can treat it earlier. Um, but though But because people are normally typically old or like the end stages of their life when they start to get Parkinson's and the signs are really advanced and it's actually impairing their daily living, they're more likely to die from something else other than complications from Parkinson's. But if you're younger and you have more time to let those advanced signs really grow or progress, then you're more likely to die from a complication from Parkinson's. Um, this I'm not going to talk about because I need to go over this by myself. Levodopa and carbidopa. This is kind of like the medications because you have too much acetylcholine but not enough dopamine. So for the medications, you essentially want to give more dopamine. So levodopa is basically like the building blocks to dopamine. So you give levodopa so that your body can put the building blocks together to get dopamine so that your tremors and your signs and symptoms of Parkinson's can go down. Carbidopa is I gotta figure out like the real differences between these two. Hold on. Carbidopa, I think it's kind of like levodopa, but it doesn't get broken down. So when you give levodopa, it's good because it's the building, in theory, it's good because it's the building blocks for dopamine. But in reality, the body's going to break down a lot of that before it ever reaches the brain. Carbidopa, it's kind of like levodopa with the building blocks, but it crosses the blood brain barrier. And the body is less likely to break that down. Um, yeah. Um, Dopaminergics may be combined with carbidopa to decrease peripheral metabolism of levodopa, requiring a smaller dose. So carbidopa kind of makes it so that levodopa isn't broken down, so that more dopamine gets to the brain. Um, Tardive dyskinesia. Your tardive dyskinesia is your like hallmark signs and symptoms of having toxicity of these medications. So essentially, your Parkinson's medications is like a on and off switch. So it's like you take it, it's working, it's working, it's working, and then it drops off, then it's not working. So you want to give the meds the same time, so that there's like a continuous therapeutic effect essentially. Um Hold on. I'm over here fucking stressed as hell. Um but tardive dyskinesia is basically the complications or like it's this is kind of how you tell if the medication's like not really working, or maybe you're taking too much. Let me see what the specifics are. So you have basically it's like jaw clenching, rapid eye blinking, tongue movement, lip smacking. Um, it's kind of like Parkinson's, but a little bit more specific. So when you see symptoms of this, you just know the medication is probably not working. What the hell is this? I literally couldn't tell you. Um, so this is food. This kind of, this is more patient centered care. Um, because people who have, Parkinson's need to, what's it called? Eat smaller foods, smaller bites, but you also have to make it look appealing, because you can't just give this to a Parkinson's patient and expect them to be able to eat it because it's big, like they can't eat it, they're gonna choke on that. But this is a pizza that's cut up, and like this is good for small pieces, but like that doesn't look appealing, So like this is kind of ideal. Something small, something appealing, so that it's kind of like to prevent depression, But here we have our nursing diagnoses. We got impaired physical mobility related to rigidity, bradykinesia, akinesia, and postural instability. So basically, you're going to have impaired physical mobility because of the rigidity and all of this stuff. So then what you would do is that, um, basically like teach the patient on, maybe wear grippy socks, or use assistive devices, or see like practice transfers, just stuff for like safe ambulation so that they could still get around, be independent as possible. um, Encourage patient to maintain a wide base of support, so like, maybe feet shoulder width apart or a little bit more shoulder width apart, like, maintain a good center of gravity. And then you want to evaluate those outcomes. So then the patient will be more balanced, more coordinated, like the gait will be better. You can ambulate successfully, just to maximize their independence, and to decrease their risk of falls. So another what's it called? Nursing diagnosis is the imbalanced nutrition. This is because, it's having difficulty chewing, swallowing, um, inability to ingest food. So, to intervene, you want to monitor your height and weight. I don't know what the fuck RD means. Um, Kind of make like a dietary plan, what the patient should eat, what the patient shouldn't eat. So maybe something more high in calories, but not something high in protein, because something high in protein can inhibit the absorption of the medications. So maybe something high in calories, but something you can like, smaller bites, easier to eat. Nothing too chewy. Teach patient and family to consume smaller, more frequent meals. Yeah. Monitor fluid and meal intake. Teach patient family to keep a food diary. So basically, I'm trying to self test here. LOL. Why do I say that? Um, so basically, make a diet plan, make a nutrition plan, no high protein, but something high calorie, frequent, more smaller meals, and then, frequent, more smaller meals, high calorie, no high protein. Smaller bites, cut it up more. Um, Outcome, it's just you're trying to maintain a constant, like, the body needs a certain amount of like nutrients, and you're trying to maintain that. So you're consuming 100% of recommended caloric intake for like their size and age. You want them to eat all of their meals, get all of their fluids, height and weight. Like when you're monitoring that, you don't want like drastic increase or decreases. Although a Parkinson's patient, there's never going to be like weight gain. That would be crazy. Um, so then another thing with Parkinson's, like I said, the impaired swallowing. Oh, impaired gag reflex, chewing, swallowing, that's related to the nutrition. So then patient education and also explain to the family, um, with Parkinson's getting more progressive, the patient may have more strugglings chewing and swallowing and makes them an aspiration risk. Basically, teach everything that we talked about up here. You also want to sit the patient up like 90 degrees or as much as the patient can when they're in the hospital bed. This is to decrease aspiration. I don't know if you've ever like laid down um, and tried to eat something like straight flat or like drink water. Like it's hard. Like you at least want to tilt and like put the chin down or like lean forward a little bit. Like it's hard and you can start coughing and stuff. So um, have a suction nearby just in case they can't really swallow or something gets stuck. Like I said, tuck the chin. Monitor tongue movement. Have rest periods just so that they don't, choke. Um, teach patient family to check for pocketed food after eating. Emergency measures for choking. This is kind of true, pocketed food, because um, the family is going to want the patient with Parkinson's to eat all of their food, and that may become like a tense issue because maybe the patient's getting frustrated because they can't eat properly and they don't want their family getting upset that they can't eat, or like everyone's just in distress, so they may just put it in their pocket or give it to the dog, or like my grandpa did, stuck it in the couch. You just find all this food in the couch, and my mom would be thinking that he ate. Oh, he's eating his meals really good, this and that, when in reality, he was just putting it in the couch. And he didn't have Parkinson's, but it's kind of like the same concept. Um, assess level of consciousness. That's what LOC means. The gag reflex, the swallowing, offer foods or liquids that can be formed to a bolus before swallowing. Um, Basically, outcomes is they can eat they're eating their meals, they're drinking their fluids, they're maintaining a proper weight, they're getting their proper caloric intake, their proper nutritional intake. They're not like choking. There's no dysphagia, or dysphagia means like difficulty swallowing or eating. Um, like just no struggles. I mean, they're gonna have struggles, but like doing what's best for the patient. Um, so they're also going to have, maybe more slurred speech, the tremors, the verbal communication. So they're also going to have trouble physically eating, speaking, stuff like that. So you want to offer more communication methods to the patient. So teach the patient to speak slowly, alternate methods of communication like communication boards, whiteboards, flashcards, gestures, something to communicate so that they're not trying to talk and just get increasingly frustrated. Um, yeah. Difficulty coping, like change in health, like mental status, stuff like that, fear of the future, uncertainty, socioeconomic. Basically, talk to the patient, like validate their emotions, tell them, it's not going to be easy, but it's like it is possible. You want to teach them all the things they need, set them up for success, essentially. And then to evaluate this, the patient will identify coping mechanisms to deal with the negative emotions. They'll have an active, like, thinking pattern for problem solving to manage the symptoms. Um, so basically, let's try and self-test here. Parkinson's is a progressive neurologic degenerative disorder. It's when You have your dopamine and your acetylcholine. Acetylcholine is the excited, dopamine is meant to match it to like inhibit that. You have too much acetylcholine and not enough dopamine because what is it called? The place where the dopamine is coming and is produced is degenerating. So you don't have enough dopamine, but you have too much acetylcholine. And the things you want to remember about Parkinson's is TRAP. Sorry, I'm itching over here. Tremor, rigidity, akinesia, postural instability. So you want to remember, complications like impaired nutrition, um, your falls, the aspiration risk. So I don't want to re-explain the nutrition and the instability, but you've got to also think of it's progressive. So the symptoms are progressive. It happens over like 15 years. So it goes from just having small tremors to now your activities of daily living are impaired to all of a sudden now you need assistive devices and a specific diet and then you're bedbound and then like stuff like that. So basically more signs and symptoms. You know, you got your shuffling, your slow gait, um slurred words, slow blinking, dry eyes, blurred vision, drooling, the dysphagia, the trouble like eating, stiffness, that's what the rigidity, poor posture, the incontinence, constipation, weight loss, shuffling gait, depression, insomnia. Um, then we also want to talk about the medications, the carbidopa and levodopa. Levodopa is like giving the building blocks for dopamine, but because that gets broken down so much in the body, carbidopa is given so that it'll help levodopa cross the blood-brain barrier so that it's not broken down so that more dopamine can be produced. But the medications are also like an on and off switch. What do I have on the back here? Um, so it's the medications, they're either working or it's not. Oh, one of the one of the complications for Parkinson's is also what's it called? Constipation. So that's part of like putting their fiber diet up to like creating that's part of creating their nutritional diet. Include more fiber so that you can get the GI tract moving. So like fruits, veggies, your fibers. Um, Again, no protein or like low protein diet. Um, yeah, I'm not sure if I'm going to know the answers to these questions, but just going to try my best. A patient with Parkinson's disease has bradydyskinesia. Which action would the nurse include in the plan of care? Instruct the patient in activities that can be done while lying or sitting. Suggest that the patient use the arms of the chair to help push up to standing. Have the patient take small steps. This is not true. We want that wide base gait, so we can take C out for sure. Teach patient to keep the feet in contact with the floor and slide them forward. It's not D because we don't. Signs and symptoms of Parkinson's is that shuffling gait, and we don't want them to shuffle more. That's not going to help. So it's either A or B. Instruct the patient in activities that can be done while lying or sitting. I don't think it's A because you want to maximize their independence. You don't want them to say, "Oh, well, you're going to be sitting or lying anyways, so here's the activities that can be done." You want them to do as much as they can, maintain as much independence, maintain as much as their activities of daily living. And I think it would be B, suggest that the patient use the arms of the chair to help push up to stand. So that would be kind of telling the patient, oh, okay, like you can use the arms of the chair to help you stand up so that you can maintain the most independence that you can. Oh, look. Yeah, maintain independence. A patient is being treated with carbidopa levodopa for Parkinson's. Which assessment finding would indicate that the nurse and the medic that the nurse indicate to the nurse that a change in the medication or dosage may be needed? So, what we talked about is the tardive dyskinesia. Those are the complications and the signs and symptoms of the medications of going wrong. So, shuffling gait. This is one of those questions where this is one of those questions where you have to know what's expected of Parkinson's and what's unexpected. So we know shuffling gait, that's an expected outcome of Parkinson's. So we know it's not A. Tremor at rest, um, with trap, the T part is tremor. So um, we know tremor is like an expected of Parkinson's. Cogwheel, rigidity of limbs, and an uncontrolled head movement. Rigidity, I don't know what cogwheel means, but we know that rigidity is part of trap. Trap, tremor, rigidity, akinesia, postural instability. So rigidity of limbs, we know that that one is an expected finding. So I think it'd be uncontrolled head movement because I remember something about the head being with the tardive dyskinesia. Woohoo! Let's see, we got it right. Uh, yeah, the other findings are typical with Parkinson's disease. Which patient problem would the nurse identify as of highest priority for a patient with Parkinson's disease and is unable to move the facial muscles? Which patient problem would the nurse identify as highest priority for a patient who has Parkinson's disease? So, highest priority for Parkinson's patient is unable to move the facial muscles. So, we want to go with our ABCs. A, airway. B, breathing. C, circulation. So, negative self image, that's not a priority because it's not like an emergency. So, we know it's not that one. Activity intolerance, this sucks, but it's not an emergency. Um, Musculoskeletal problem or nutritionally compromised? I think nutritionally compromised might be the most highest priority, but because with nutrition, you can have that impaired airway if you like choke on something. And it's also because nutrition can lead to a musculoskeletal problem if you're not getting everything that you need. Yeah, decreased swallowing. See, those ABCs. Are we almost done? I'm fucking over this. A patient with Parkinson's disease is admitted to the hospital for treatment of pneumonia. Which interventions would the nurse include in the plan of care? A patient with Parkinson's disease is admitted to the hospital for treatment of pneumonia. So they have pneumonia. Which interventions? Cut the food into small pieces. This one has to be it because pneumonia means they also probably have an aspiration risk. You want to do this anyways. Serve high protein, not this one. That impairs absorption. Place armchair at the patient's bedside. So, okay, we definitely know it's B. We definitely know it's E. You always want to observe and assess for exacerbation of symptoms. Provide an elevated toilet seat? I don't. If this is the exam, I wouldn't put this one because I'm not sure. And if you put a wrong answer, then you get minus points. But if you don't put the correct answer, then you don't get any points taken away. So I'd 100% put B. I'd 100% put E. I think I would put D. I'm not sure. Difficulty chewing. Food would be cut in small pieces. We know that. An armchair would be used when the patient is seated so that the patient can use the arms to assist. See, that's what I thought because that's what we had talked about that previous question for. Maximum independence. Okay, ABD. How come not E? Oh, it's progressive. There's no acute exacerbations. I was thinking of acute complications like pneumonia. What the fuck? Questions. Okay, so this was a pretty good review for me.